Today we're going to talk about breast cancer screening. We're going to talk about the mammogram, when you should get it, and who's at higher risk for needing to have it maybe before the age of 40. Today I'm going to talk with a breast surgeon in my community, Dr. Mossadegh, and we're going to have a discussion on some of the things that we talk to patients in the office who are at high risk for breast cancer or who have an abnormal mammogram or who are just wondering when should they start breast cancer screening. That sounds good to you? Continue watching. Alrighty, so thank you for joining me today. We're going to talk about breast cancer. So October is Breast Cancer Awareness Month. And, I see so many women that have insurance but still don't get their mammograms. And there's so many different reasons. And so, I'll see someone in the office for discharge or bleeding. And I always ask them, have you gotten your mammogram this year? And I was surprised at how many women just, I'm too busy or I don't have time. I had one patient that was referred to me this year for prolapse, and I don't treat prolapse, but I referred her to someone who did, and then she hadn't had her mammogram in a couple of years. I was like, I'm going to go ahead and refer you to, this doctor who's a urogynecologist, but let me get your mammogram. And she wound up having breast cancer. Had no symptoms, no family history, just was behind a couple years on the mammogram just because life had gotten busy and she'd moved. And so I try my very best to just make sure all women get their mammograms. So when you see patients in the office and they say, well, I don't want to have it every year, I worry about the radiation, or why do I need to get a mammogram? I had one last year. What do you tell them, or what are some of the things you want them to know?
Yeah, thank you. That's a great question. I think especially with COVID and then post-COVID, things got busy, things were shut down, and then patients just sort of lost track of time sometimes. I think it's really important for women to know that mammograms are a screening tool. So what it does is it helps us detect calcifications, which are not palpable. So you're not going to be, so these calcifications can only be seen on mammograms. So you're not going to feel a lump, you're not going to detect a lump, and the majority of women that we're treating with breast cancer have no family history. So I think sometimes women have a false sense of security, thinking, well, nobody in my family has breast cancer, so I'm okay. But that's really not the case, because the majority of women with breast cancer do not have a family history. So I think it's really important for women to understand that the mammogram is just a screening tool. And just because you got one last year and it was normal does not mean that this year it will be normal. So we need to check mammograms starting at age 40 every year. And then sometimes women who are in their 70s, they think, well, I'm too old for this. I'm too old to get breast cancer. And that's not true either, because if you live to be 90, and you're 70 now, that's 20 years of living with these breasts. And I think if you're proactive, the chance of you catching something abnormal at an early stage is much greater. And then, of course, the survival is much better. I think women are afraid of the radiation. But honestly, they've done a lot of studies about the radiation. And so the amount of radiation you get from a mammogram is about equivalent to 6 or 7 weeks of just normal life. So the radiation you get from the sun or your microwave or your cell phone. And if you add that up for 6 weeks, that's pretty much the typical amount that you get with a mammogram. And it literally can be a life-saving measure. So I think it's real important for women to make sure that that's part of their self-care.
Yeah, that's really great. I had a patient last year that was 90 and she was diagnosed with breast cancer. And so in terms of when to stop screening, I usually will ask patients, if we found something, do you want something done? Because I know there's no upper limit of guidelines, such as like the Pap test. We usually stop at around 65 in low-risk women that have had normal Paps, but there's really no kind of upper age limit for mammograms.
Right. And that's exactly true. But I think that even if you're in your 80s, if you're healthy and your risk is minimal, doing a lumpectomy, which is a small outpatient procedure, of course, you don't have to go through things like chemo and radiation and things, but removing the cancer off your body, is is a good option for a lot of women who are in their 80s and even 90s. So yeah, it's definitely a conversation. It's definitely an individual choice. And so it's absolutely important for women to, talk to their doctors.
Mm-hmm. I definitely agree. And then I know I've read some guidelines that said, if your life expectancy is more than 10 years, and to continue doing your mammograms as well, which is what you talked about in Good Health. So let's talk about, let's say someone that's had their ovaries removed and they want to do hormone replacement therapy. Now, I definitely believe in the treatment of menopausal symptoms for symptomatic women. So not everybody needs hormone replacement therapy, but some women really do suffer and do need it. So what are your thoughts on kind of hormone replacement therapy in the older woman that's maybe postmenopausal or had their ovaries removed?
That's a great question. So I think that, as you said, hormone replacement is great for a lot of women, but in some women who are considered high risk, it's important for those women to be identified and kind of treated a little bit differently. So what I mean by that is, so if a woman has a family history of breast cancer, if a woman has had a abnormal biopsy, even if it was not cancerous, if it's considered a high risk benign lesion, if a woman has dense breast tissue, and if a woman has not had their mammogram and has not had a good workup, I think they should proceed with caution, because there are certain types of breast cancer that can be fed by estrogen. So I think that, again, I think it's important for each individual woman to, not do what their neighbor's doing, what the lady at church is doing, what they read on the internet. But I think it's really important for each individual woman to talk to their doctor, assess their risk. If their risk is 20% or higher, they could, consider things like antidepressants or alternatives to hormone. Obviously, if a woman has been diagnosed with breast cancer, and if that breast cancer is a hormone sensitive cancer, then we of course tell them to stop their hormone replacement. So I think for the majority of women with no risk, it's absolutely safe and it's good for them to treat their symptoms. But there is this other group of women who sometimes they don't really know their risk, or they don't really know their family history. Maybe families don't, routinely talk about their medical problems. So in that case, they can still do genetic testing. They can still do a thyrocusic risk assessment and discover if their risk is high, then maybe they can avoid the hormone replacement.
Yeah, that's a good point. No, that's a very good point. Yeah. And I've been doing a lot more genetic testing. Now that the prices have gone down, it's a lot more affordable for most women. Even if insurance doesn't cover it, I tell patients that they want to self-pay, that's actually, more reasonable than it used to be, because their cash prices are $100, $200, so much more reasonable than they used to be. Great point. Yeah. And I think that's why too, the American College of OBGYN really encourages us to not put people on hormones forever. 5 years is really what I try to shoot for. And then I tell patients we're going to kind of discuss after 5 years, I don't want you on it forever. It's, just to control your symptoms for a short amount of time. And I do have some patients that are able to come off in a couple of years, and some people that just want to be on it forever. So at that point, it's the shared decision-making process. But that's very good point.
I think every woman has the right to just make her own decision, and if quality of life is very important. So if you don't want to have longevity with poor quality. So I think that's where the individual, patient-doctor relationship is so important, because we can assess each individual and, figure out what's right for them.
Yeah, exactly right. And, I have sent some patients to you that, let's say, have had, early breast cancer or a mass that the radiologist said needed to be excised. So when those patients see you, kind of what should they expect? Or, they're always nervous. They don't know I had one patient that said, is she going to just cut my breast off? And I was like, no, we're going to do a bigger biopsy first. But, they're scared. So what do you talk to them about when you see them in the office?
Absolutely. Well, that's kind of like a two-part question. So we've got the patient who has a benign breast lump, maybe a fibroadenoma, maybe a phylloides tumor, maybe it hasn't been completely worked up. And then, of course, we've got the patient with breast cancer. But I think step one is to sit down with the patient and get to know the patient. What's their medical history? Tell me about your heart history. Tell me about the medications you're taking, your family history. It's basically my time to investigate. So what I tell patients is that, that's kind of chapter one. Chapter one, I'm just trying to investigate. I'm trying to collect all the data, all the information. So when that patient comes to see me that first appointment, we're not really making surgical decisions that they're really afraid of. I think it's partly me discussing their particular problem, educating the patient. Because knowledge is power, and sometimes patients are pre-reading on the internet, and although the internet is filled with wonderful information, it's also confusing if you're not aware of your specific case. It can kind of, lead you down that rabbit hole of confusion. So a lot of that first consultation is me figuring out their history and then trying to educate them on their particular issue. And then sometimes we have to order additional testing. So maybe they've had a mammogram and now maybe they need an ultrasound, or maybe they need a breast MRI, or maybe they need genetic testing. So I think that that visit is me talking a lot, trying to educate them, trying to inform them, so that I think when the knowledge goes up, then the fear level comes down to a manageable place. So that's kind of that first visit. That's kind of how it goes. So yeah, there's usually no discussion of what are we going to do right away, because I think that they need some time to process a lot of that information.
So what about patients that are high risk? So let's say our BRCA patients or someone who has a very strong family history of breast cancer. When should they start screening?
That's a great question. So women who are high risk, and those women are considered having 20% or higher lifetime risk of developing breast cancer. So those women, we recommend that in addition to their yearly mammogram, they have a yearly breast MRI. So at a 6-month interval, so let's imagine my yearly mammogram falls in January. Then in June or July, you're going to have a breast MRI. So breast MRI, there's no radiation. It's just sound waves. You get injected with gadolinium, but it's safe. And the reason for that is that young women specifically who have dense breast tissue, sometimes there are certain cancers that can be missed with just a mammogram or an ultrasound alone. So in women who are 20% or higher, they really should be getting a breast MRI yearly in addition to their mammogram, and their insurance will cover it. And it will cover it because we can actually enter their information in a computer data system, and it will calculate their risk so that we can defend the MRI with the insurance company. Also, for women who are high risk, it's important because sometimes a woman will get a biopsy with a high risk cell, and they're told that this is not cancer. And so when they hear that this is not cancer, of course, they're relieved, they're happy, and then they ignore the high risk situation of it. But a lot of these high risk cells, they still need to be excised, because breast cancer, if you can think from a normal cancer cell, there's a continuum of changes that happens in the breast. So these cells can become funny looking for years, for a period of time. These are high risk benign lesions that can, if left in the breast, become cancer in the future. So I think it's really important for women to educate themselves in breast cancer, but also understand that these high-risk benign lesions also need to be excised to prevent them from becoming cancer in the future.
Great question. Great answer. Yeah. And then I will put in the link below some of the risk models that patients can actually go themselves to see what their risk score is, just in case they're not sure. So I'll definitely put that in the link below. Well, anything else you want patients to know just about breast cancer screening and the importance of mammograms? Maybe something you would tell your patients or your family members?
I think it's important. I think it's part of our self-care to take care of, our breast health. I think that some group of women try to avoid this area and avoid getting screening because they just are afraid and they just don't want to know. And, the problem becomes that then when the cancer becomes more advanced, it's going to show itself. And so by the time something is large and it's palpable, or it's spread to the lymph nodes or other organs, it makes it much more difficult on them to endure the treatment. So I think I just encourage women to do their screenings, meet with a physician, figure out what their certain risk score is, and then not be afraid of the imaging modalities, because really it's meant to protect them. It's meant to find things at a very early stage. There are breast cancers that are stage 0 that can be detected, that are easily removed. There's no deformity to the breast. It's a quick outpatient procedure, and you can keep on going. So yeah, I think also it's important, whoever the youngest woman is, whatever age that woman is in your family, we recommend 10 years earlier to start screening. So if you have a sister and that sister was diagnosed with breast cancer at age 42, then really at age 32, that the other sisters in the family or the daughter, any blood relative needs to be screened 10 years younger. So that's really important to know that, yes, we say for the average woman, 40 is when we start. But of course, if someone has a young woman in the family with breast cancer, they need to start 10 years younger.
Right. Yeah, that's great to know. 10 years younger and the youngest person in your family who's been affected with breast cancer. Well, Thank you, Dr. Mossadegh, for your time. That's all I have today. And thank you so much for sharing your insights with my patients. Thank you for caring for so many of my patients. I do appreciate it. I will put your information below if anybody wants to reach out and see you as a patient. And thank you so much for joining me today.
Thank you so much. I'm so glad that you invited me and are sharing in this proactive, can't think of the word, but sharing with me the breast health education.
Yeah, so that women have their own self-care. Yeah, that's very important because we don't think about breast health. It's something that we don't, think much about, but we should, because it's very important. And it's number one cause of death in women is number one cancer in women worldwide is breast cancer. So
thank you so much. I appreciate it.
Thank you, Dr. Mossadegh. Have a great day. Okay, bye-bye.
Thanks, bye.
Well, I hope you found that helpful today. So what Dr. Mossadegh and I talked about is really the importance of self-care for your breast. I will have my patients in their 20s start doing their self-breast exams, not because I want them to find a lump, but I really want them to know how their breasts feel, because I believe that over time, if a woman knows how her breasts feel when something is different, then she'll be able to recognize that. And so I have several videos on how to do self-breast exam. I have videos also on the screening mammogram and why you should do it. If you have any comments or questions, please put them below in the comment section. I will put a link to some of the breast cancer risk models that you can use if you're curious to see what your risk is. As Dr. Mossadegh talked about, there's like a 20% threshold where we say you're at higher risk. So for most of the breast models, if you're over that 20%, a lot of times we will do breast cancer screening every 6 months. So those are the patients that are at highest risk. So they normally will get a mammogram once a year and breast MRI once a year. So typically we alternate those so that you get some type of breast screening every 6 months. But remember, that's only for the women that are at the highest risk. So those whose risk scores are over 20%. Well, I hope that you found that helpful today. I hope you learned a little bit about how you can improve your own health and the health of the women in your family. And I appreciate you staying with me till the very end and watch this video next. Thank you.